everyone. I would like to, before we begin, to ask for a volunteer to help me stay track of time. So at 2:40, you can just give me the wave. I appreciate it. I'm going to introduce the panel, and then we're going to go by first names. And this list is in no particular order. It's the order that was given to me. So when I call your name, just wave at the camera. David Carnish, Director of Education, ACPE. Douglas Stewart, APC President. Dallas Speight, Chief Executive Officer, CPEI. Reverend Dr. Rachel Greiner, Diplomate Supervisor, CPSP President. Reverend Dr. Garrett Bugg, CPSP Vice President. It's nice to meet you. I was wondering who you were. Okay. Yes, you did. Augustine Drew, NACC President. If you are in the web room, Zoom room, would you please wave? Okay, all right. Oh, there we go. All right, I see you. Okay, it's good to see you. Great. And Rabbi Joseph Ozarowski, Board Member at Large, COMISS. Wonderful. And also past president of NAJC. Let us give a warm round of applause for our guest panelists. We're here to talk about the state of chaplaincy in 2026, and we're going to get right to it with a list of questions. And then when I direct questions to you, members of the panel, once you are done, we will pivot to the audience to see if you have any feedback. We have 7 questions where hopefully we can cover a lot of terrain at this time. The first question: while much of the public view of chaplains, while much of the public likely views chaplains in a stereotypical way, older, white male, Christian, praying with a patient, how would you define what a chaplain is? How are chaplains and CPE programs working to break preconceived ideas of what chaplains do in all the various settings they work in across the ecosystem? So again, we're going to start with first names. I'm going to use first names, no disrespect. I've given you your propers. We're going to go with Doug, Rachel, Garrett, and Augustine in that order. Take it away. Use the microphone.
All right. I really don't have a lot to say because I got an hour and a half to already say that. But being a preacher, I'm going to say something. We really have to change that perception of that guy or gal who walks in, prays, walks out, and life is wonderful again. Doesn't work. So moving forward, that chaplain who is engaged, integrated, innovative, and also he or she can tell that story to other people. That's kind of where I'm going for what a chaplain needs to be.
Awesome. Rachel.
Well, I appreciated your presentation today. Thank you for that. I always say that chaplains are theologically educated, clinically trained, culturally competent, and spiritually informed. So when I'm looking for, when we talk about CPE and what that means, how are we trying to break some of these stereotypes, is by making sure we're educating everyone that is what we do. You've heard a lot of ideas already today about speaking in the C-suite and talking with your new employees in the HR world, which I think are all wonderful. And then it's the boots on the ground. It's the nurses that see you having deep, meaningful conversations with people that you didn't come in and pray with. You didn't come in and beat them in the head. I think the education piece is huge. Garrett?
Education is quite important. I also, first of all, I do have to admit, I was trained by a whole bunch of old white men. And most of them were Christian. But never did they advocate praying and leaving. So I think we also have to be clear, regardless of our age, of what we were actually trained in. Because I think to fight against this stereotype, we need to both acknowledge it, and then we need to demonstrate over and over and over again that it's not what we do.
Thank you. And we're going to pivot to the Zoom room. Augustine, please unmute yourself and share with us your response.
Thank you. Can you hear me okay?
Loud and clear.
Oh, wonderful. Thank you. And I apologize, I'm not in the room with all of you, but really happy to contribute a little bit about this particular question. What I love about the question was your comment around the identity of a chaplain, and really the notion that chaplains stereotypically older white male Christians, right? And I think the idea is that today, if you look around the demographic of chaplains, there is a huge diversity of individuals who serve in chaplain roles. And I'll tell you from our experience within NACC, it used to be a lot of our chaplains were priests and religious sisters. Today, when you look at that demographic, only about 20 or 30% of our members are priests and religious sisters, right? So the vast majority of chaplains we have are people who sit in the pews every day, who are not ministers in the true sense of it, but individuals who are called to ministry in ways that are profound as they bring their gifts to bear in helping address the human need that are out there. So chaplaincy population is so diverse these days, and it's continued to, I have a sense, if the trend continues the way it is, it will continue to diversify in the coming years.
So here's a follow-up question. These are the zingers, and this is for the panel. If indeed the saying is true that you can't be what you have not seen, and we're talking about doing a new thing, where are those tension points, and how can we navigate them if we're moving to a new model of what a chaplain is, how a chaplain moves? Anybody? You can raise your hand and unmute yourself, and go ahead, Doug.
I'll say a couple of things. First off, Rachel, I really appreciate your definition. I like that one. That was very well said.
Oh, sure. Theologically educated, culturally competent, clinically trained, and theologically and spiritually informed.
Doug?
You want to repeat the question again?
Yes, I can.
Okay,
I can. If the saying is true that you can't be what you have not seen, and we're talking about doing a new thing, breaking away from these stereotypes, the tension, the wrestling, the pinch point, how can we navigate that space?
Okay.
Apologize for the interruption.
Yeah, go
For
ahead.
some reason, we can't hear you all.
Okay, we will make sure that when we speak, our mics are unmuted.
Yes.
And you will know that your mic is unmuted when it's red.
All right.
Yes, it's hot. Go ahead, Doug.
Okay. I think that, first off, that's a great question. And it's really part of it's talking just about change management. People step into things all the time. They don't know exactly what they're stepping into. That's the adventure of exploring new things. One of the things you got to be, for me, you got to be willing to say, I'm going to try this, and it may fall flat on its face. But then you got to dust yourself off and say, well, that didn't work, but let's try tweaking it a little bit to the left or to the right.
Mm-hmm.
So if we're doing something, some end-of-life care, and it really doesn't offer a lot of benefit, how can we do it again? And stand it up, try it again, and keep plugging at it, because we are in space that we don't know. If there's a set path, we probably would have already walked it. I do a lot of hiking. It's easy to follow a trail that you can see for a mile down the road. It's hard to step off to see where that next new path is. And it can be a little scary, recognize it's scary, recognize we don't always know where we're going, but that is a statement of faith to step forward and do that.
Thank you. Rabbi Joe, I saw you on mute.
Thank you. I'm going to respond to this from my own perspective as a Jewish chaplain who operates in the Jewish community. So that means I may appear to be an older white male, although some of my black clergy colleagues have told me, and I'm quoting here, that Jews are also people of color. That's a separate conversation.
Yes, it is.
Christian? No, I'm not actually. Praying with a patient? Sometimes, occasionally. But part of the challenge that I have had is being able to sell professionalized chaplaincy in my own community. I manage a Jewish community chaplaincy program, which I'll talk a little more about later because it fits into one of the other questions we have. But trying to convince people in my own community that a professionally trained Jewish chaplain might be helpful to you has been part of the work that I do. There's a dog and pony show that I've developed, and I go out with colleagues, and we meet with board members and our colleagues who are in the therapeutic community and with fellow rabbis to let them know what we do. And what Doug did earlier today was a great presentation, and we've used some of those in other frames and other contexts, but that language, we deal with the gut issues of life, with meaning, with suffering, with purpose, with hope, things of that sort. It's not easy selling it, but I think it's an important project, and it's something we have to do if we are to remain relevant in terms of the value. We know how valuable we are. We need to be able to convey that to the others, and I've done that with my own community. The one thing I've also mentioned in the Jewish community, what we're able to do for Jewish clinically trained chaplains is connect aspects of Jewish tradition to the work that we do. So if you're someone who is Jewish and in a healthcare setting, having somebody who speaks your religious and or cultural language, and that's a key and or, by the way, and I'm going to talk more about it later, that's vital.
Thank you. Two microphones are lit, so I'm not sure which one of you two.
I was just going to add to that, Joe. I think a big part of the way that we get in those tensions and that we can work through them is by doing stuff like this, being together with all types of different chaplaincy places, different chaplaincy ways that we're practicing in the field. We're all going to have different areas of growth, and we can't be so siloed. We don't have to recreate the wheel every time. We have a lot of information to offer each other. So I think relationships are a big part of that.
Wonderful. David?
The quote by Adam Grant, he wrote a wonderful book about organizational psychology. His quote is that we need to be focused on being good ancestors instead of being dutiful descendants. That's a quote that I carry with me from day to day. I just wanted to make sure that I had it right, so I looked it up. But I think chaplaincy and being a good steward of the future is about something that's age-old with humankind, and that's the sensibility. What's the word sensibility mean? The word sensibility has to do with the capacity to feel, perceive, and respond to emotions, aesthetic, stimulus, and intellectual and moral influences. I don't know of a human being on the planet that doesn't struggle with all those things, and it changes over time. I think where we've struggled, COMISS, ACPE, all the other cognate groups that are in this room that certify bodies, that endorse people, that train people, is that this tension has always been there, and we've sort of always looked backwards to how do we please the people that were before us. I don't think we can do that anymore.
And with that, let us pivot to the next question. Someone once said that chaplains or those in the ecosystem of professional spiritual care can be like herding cats. So let me ask the question. Chaplains, like all professionals, approach their work with their own perspectives, styles, and foundations. However, the work of chaplaincy and spiritual care requires shared, emphasis on the word shared vocabulary, goals, and competencies. Here's the question. How can professionals promote a standardized language in the field of spiritual care? We're going to go from Dallas to Joe to Garrett to Augustine in that order. Dallas.
Sure. Regardless of one's political ideology. This whole issue was brought to focus recently when Pete Hegseth addressed the issue of chaplaincy in the military. He said, and I'm quoting, "We're going to restore the esteemed position of chaplains as moral anchors for our fighting force." Then he went on and quoted an older chaplaincy manual, which states, "The chaplain is the pastor and the shepherd of the souls entrusted to his or care. This is a high and sacred calling." What I have become aware of, particularly in recent days, is the number of programs, not only increase in CPE training programs, but in chaplaincy programs. I looked on the Chaplaincy Innovation Lab.
Yeah.
There are 40 programs listed on there. Some of them are faith group, but 40 different programs that are training chaplains. And I walked away from that, and there's different kinds of chaplaincy training, certainly needs. But there is a need for some standardized curriculum or competencies. I am so appreciative of the changes that have occurred recently, not certainly to ACPE, but the fact that it's opened up some avenue for us to partner and talk and discuss issues for us to work not only with NACC, but APC and others from our organization's perspective. And I guess the question I would leave us with, because we can voice all kind of problems in this venue, but what are some solutions? And as I thought about this over the last week or so, I'm thinking, it seems to me that there needs to be a voice that somehow speaks to this, and I don't know of a better voice than COMISS. But it's certainly not been happening. I don't know. Frankly, I don't know too many folks out there that even know who COMISS is. But rather than ACPE or CPEI or APC or whoever speaking to some issues, this seems to be a venue that could ultimately set some common standards and ideas.
Thank you. Joe?
This is a really good question. How do we develop and maintain a shared taxonomy of spiritual care? There have been attempts to do it. I remember sitting in on one. The research was done through the Advocate healthcare system in the Chicago area. It extended beyond Chicago. It was really interesting. I don't have it in front of me. But since that presentation 7 or 8 years ago, I haven't seen anything else about it. So there's work that needs to be done to develop a shared language. There are research outfits out there. You've got Transforming Chaplaincy and Chaplaincy Innovation Lab. But as Dallas just pointed out, the stuff that they're including doesn't all hang together. I'll give you one micro piece of this. When Wendy Catch was doing her study of Jewish chaplaincy, and I was involved in that study, she was lumping together healthcare chaplaincy, which is what most of us represent, military chaplaincy, which is partly represented here as well, but also police chaplaincy, fire chaplaincy, educators chaplaincy, and they all have different standards and different trainings and different everything, which makes it really, really hard. My critique of Wendy's research, and I said it to her, is that you can't just call anybody who calls himself a chaplain a chaplain. You can do whatever you want in research. When it comes down to a professionalized standard, there's got to be something that we share in common with each other. So, and I suggested that chaplaincy training might be a place to start. So CPE training has a shared language, maybe. I'll get back to that in a second. And a shared culture, maybe. Which brings us to the question of different CPE programs, which Dallas alluded to as well. At one time, it was mostly for most of us ACPE. Now it's not so much anymore. I had lunch with the leadership of CPSP, which was fascinating for me. Actually, it was a great conversation. I've always been asking, so tell me, how does CPSP training differ from the ACPE training that I had and most of my colleagues in NAJC had? And I learned a few things. So I think it's opportunities like this, COMISS, the Common Council, other places that give us the opportunity. There's also a need for research. Research takes money, and it takes staff. That isn't so easy. Where does this all come from? But I think we need to find a way to do it in order to create the shared language and the shared culture to define professionalized chaplaincy.
Thank you. Garrett and then Augustine.
There we go. Thank you. Well, here. I think, Joe, you're right on it with, and Dallas, as you were as well. I think our common cause together needs to be fleshed out. COMISS, again, it would be a great place to do that since we're in one room together. This is unusual, or has been, at least in the history of our common cause as chaplains. So, whether we find that common ground within our CPE training programs or the simple application, regardless of whether we're practicing in a hospital, in a community-based program, in a military setting, in whatever setting, if the action reflection model is going to be one of those basic foundational pieces, let's name it. Because otherwise, we're just kicking the can down the road. So we need to get after this work pretty quickly, and I think today's a great place to begin.
Wonderful. Augustine.
Thank you. And I will agree with the comments of the other panelists that we have shared already. One thing I want to add to this is the piece around the recognition that to develop a common language, you have to have an element of education, right? Educating the community of practitioners of professional chaplaincy in such a way that we can share one language at the same time as an awareness of the understanding of the contributions that chaplaincy bring to the larger community. And I want to share one example of the importance of education. About a few years ago, in 2020, there was a study that was done by the University of Louisville School of Public Health and Information Services, CHOT, in partnership with NACC and APC, to look at the ways professional chaplaincy organizations certify their members and how this has implication for the future of chaplaincy. And I think that's one example of a work that really we can continue to lean on to help us understand what we need to do as strategic partners, in chaplaincy, to really enhance a common understanding and shared vocabulary around professional chaplaincy.
Thank you all. Follow-up question.
And I think there is a question online. Someone raised their hand. I don't know if
Is that right? Would you unmute yourself if you have a question and ask your question if you are online, please?
Yes, thank you. Stephen Wojtowicz, I am an endorser and past chair of COMISS, but also a trained clinician in pastoral care with a number of bodies that are represented by COMISS. So I just want to take this opportunity, one, to say how wonderful it is to have the present panel representing all of these bodies who are in dialogue together. I can't say that loudly enough. No matter where this conversation goes, the fact that we could be in the same room and be in dialogue is so important. I want to just offer a dream in saying that it is my hope that one day, if COMISS becomes a place for that conversation, there could be a federation created where all stakeholders in pastoral care and training could have a voice. And through that realm, then there could be an opportunity to really build the kind of training approaches that we're talking about here that would allow each organization to do their training uniquely, but ascribe to a similar set of values and training. So that's my dream as we're here today.
Thank you. Follow-up question. Similar but not the same. In healthcare, when one goes to the hospital and before they are discharged, we have coders, medical coders. Their Bible is the DRG. I'm wondering, with these larger electronic health medical record companies where it seems as if they're taking over, like Epic, and they have these data sets for professional spiritual care. I'm wondering, will that force change in the ecosystem where we will have to work with them to adopt that language? And so I'm just curious, I'm just throwing that out there. Thoughts? Do you think that the DRG will force change upon us, especially when we get written in with those 4 CMS codes?
I don't know that that'll be a force. It's a great question. I was just thinking, all the people that we credit as our fathers and ancestors and mothers in CPE that trained all of us in the room and on Zoom, the one name we never mention is Helen Flanders Dunbar, who was really the leader in psychosomatic medicine, who said we need to be working on social, psychological, and behavioral, as well as relational problems that form around illness. And we need doctors, nurses, social workers, and clergy to be working together on that. And so I think that is the missing piece of our history that we don't pay attention to, and her voice in particular. And I don't know how that ties to those coding systems, but it seems like we have been too siloed to even be a part of that conversation. And in a healthcare system where we're in an industrial country like we are, where healthcare is not a right, it's not a privilege, it's a commodity, I think we're probably, and COMISS could be more of an advocate for how do we not only participate in that system, but also break it.
Thank you. Joe, your mic is on?
No.
Oh, I thought it was. Anyone else from the panel would like to muse out loud? Go ahead, Doug.
Yeah. So we've got the HCPCS codes, the
Yes.
4 HCPCS codes. That's a start, but we've also got to figure out, do we need something specialized for us? So you've got the DRGs,
Yes.
but, DRG is gallbladder, uncomplicated, gallbladder, minor complications, gallbladder, major complications. What would we want something like that code to look like for chaplains? Not so much that we're going to get reimbursed from CMS, but be able to code something that becomes meaningful as part of their medical record. What is that? Is there, does there need to be like a PTSD code related to a traumatic event? We've got to figure out what we even want to be able to code as part of that medical record. And that's one of the struggles. And then what are the interventions? The other part is, if you document it, what's your intervention? And can you show an improvement on it? It creates, as I'm processing that and going, there's a lot of things we would have to work out to get there. And what are those spiritual things? And then, is that ever going to impact reimbursement? Because when we also look at DRG reimbursement, if you've got a gallbladder, and I'm making numbers up here, it's $5,000. Minor complications, $6,000. Major complications, $7,000. That's all Medicare is going to pay. How does, but spiritual care often fits into those major complication cases with gallbladders. The minor ones, they're not even in my building long enough for me to see them. But if you have a gallbladder case goes bad and they're there with complications, comorbidities, they're landing in the ICU on one of my high-need floors. Somebody is going to see them and start taking care of that. So how do we even tag on to that DRG and get something that says, yeah, spiritual care needs to be a part or a component of that care plan, and hardwire that in? And that's some of the questions. I don't have an answer, but I'm pondering the questions we need to ask.
And that is why we're here. We're going to pivot to our third question now. In your experiences, are chaplains considered essential workers? Are online chaplaincy services impacting the workforce of in-house chaplains? What impact, if any, are these changes having on providing spiritual care for colleagues or as part of an interdisciplinary team? We're going to start with Rachel, Joe, Garrett, and then Augustine, in that order. Rachel.
I got really fortunate to work in a center during COVID where chaplains were essential workers. We were not sent home. We were there every day. And I still work in a facility that believes that. I know from a lot of you, from some other colleagues, that that wasn't the case in all healthcare, which maybe goes back to the education. Maybe they didn't have an advocate speaking the right language in the right places for folks to know exactly what it was that they were doing. I think when we look at, there's two pieces here. We look at being essential workers and what does that mean? How are we articulating that? What other things are we doing? We're doing ethics. We're doing patient family councils. We're holding so many things at the same time, which makes us more essential. And how do we make sure that those things aren't getting lost? That it's not that Rachel is in charge of all these other things, but that Rachel is a chaplain, right? Like, I don't want to lose that piece of it. I think online chaplaincy and telechaplaincy, we're seeing more of that now. I think it could supplement in-person chaplaincy, particularly in an acute care facility, but it's not going to replace it. You all know that it wouldn't be the same, right? Talking to somebody on the phone when your mom died is very different than holding somebody's hand, than being present. I'm hopeful that it can be useful in some of those more rural areas where it's more difficult to get a chaplain in person there at 2 a.m, but I don't want to see it become the norm.
Thank you. Joe. Turn your mic on, please. Thank you.
I'll pick up where Rachel left off. COVID taught us, the pandemic taught us an awful lot of lessons. How do you offer spiritual care when we're all wearing spacesuits and not allowed to go here, not allowed to go there? And it was really quite an experience. I was still doing some hospital work. I spent 15 years doing hospital work outside of my JCFS job. And I will never forget, I had to pray with somebody on the phone that I couldn't see using a language line. They didn't teach me that in rabbinical school, and frankly, they didn't teach me that in CPE either. But you know something? We learned how to do it. We figured out how to do it. The most profound experiences of doing end-of-life prayers, Jewish end-of-life prayers, wearing a spacesuit in the ICU with a patient dying of COVID. I will never forget. Those will be imprinted really in my brain. We've learned a lot of things from that. In my main job at JCFS, we were not allowed to go into the senior facilities. We service about a dozen of them. We do one-on-ones. We do programming Friday afternoon, Shabbat, Jewish holidays, and we just couldn't go in there. So we had to pivot very quickly, and our team developed a series of videos, one for Fridays, for Shabbat, for the Jewish Sabbath, and for major Jewish holidays, Rosh Hashanah, the Jewish New Year, Passover, Hanukkah, and we shared them. We raised some money for it, and we shared them with our facilities because we couldn't go in there. That did a couple of things. It served the patients, it served the residents, the clients, but it also kept us in these facilities. I would have to say, based on those experiences, that COVID reminded a lot of people how essential we were, because we could do things that pretty much nobody else could do when everything else is lost and it's the end of life. And this is where prayer actually does become important. When there's not much else you can do, that's the one thing left you can do. And we were able to do that. And based on that, we were able to market the types of things that we do and sort of practice the things that Doug was actually telling us this morning in terms of how to show our worth and the worth of what we do to the higher ups, the people you call the C-suites and the other places.
Thank you. Garrett?
Well, I will start this answer by saying, yes, chaplains are essential workers. My experience of that as a church leader, actually during COVID, was the correspondence with the chaplain at the hospital who was caring for the parishioners that I had there, because I couldn't go in. I couldn't be anywhere nearby. So that was a very important moment. Online chaplaincy services, I think, as Rachel mentioned, I think as a supplement, those might be very helpful. As a CPE supervisor, I have run online units of training, which are also very helpful, but one of the major challenges of that is making sure that the students who are completing online clinical pastoral education can function as part of an interdisciplinary team. Because sometimes they just can't because of where the clinical setting is. So there are challenges with online chaplaincy that still need to be explored and still need to be resolved.
Thank you. Augustine. And then we'll
Thank
come to
you. I would also echo the point that chaplains are essential. I was, like Rachel and others, I was fortunate to serve in a ministry that really insisted that chaplains are on site throughout COVID. And not only supporting families and patients, but also supporting caregivers, associates, and staff. And I think this is a space where the online platforms of virtual chaplaincy has better, stronger and greater potential in terms of serving not only patients or families or caregivers of patients, but also serving individuals who are taking care of patients themselves in the healthcare organizations or outside of healthcare. I do think that organizations are adapting, organizations are changing. Chaplaincy has to adapt and change along with these organizations. And this provides us a unique opportunity to be able to adapt and ensure that we're meeting the needs, both virtual and also in person.
Thank you. Anissa. Did I say your name right?
You did. I'm impressed.
I know someone with that name.
Okay. Two things I'm reflecting on and feeling as we go through this. I struggle with the valuation of in-person care and distance care being evaluated under the same rubric because it's different. And if we only use one rubric, then we're being ableist. So, for instance, I'll give an easy example. I've changed my language. Instead of saying people who are in person and people who are online, we're all in person. So I say people who are online or in the room, or we're all in the room. I change my language around that. So, I mean, I totally understand. I'll be honest. I've worked with an organization that did distance care, that only used board certified chaplains, that did it in the right way, that served a rural community, all those things. But I just those valuations just are not accurate. It's like reading a book and saying the movie stinks because it's not like the book. But the movie is a different venue and a different way of relating a story than a book is. And I think we don't think about pastoral care that same way, saying it's different, but that doesn't mean it's better or worse. And so I'd like to hear some around how you all evaluate that because I know some of you are very experienced in online learning and some of you are not, probably. So I'd like to hear something about that and the ways you alter your education program with standards. And by the way, I think this is where COMISS can step into because a unified standard would be good. But then the interpretation of how it's delivered can change. So.
Sounds like subgroup task force. However, we have our panelists here. Who would like to take a stab at that? I see two microphones. We'll go to the end, Dallas, and then we'll come right here with you, Joe.
So I'm not going to address your question per se because I don't think I can, and others here can probably do it. But what I wanted to say, and I appreciate so much Doug's presentation this morning, because I think the need and innovation. I saw the need back in early 2000 to do CPE online. Others criticized me. Thankfully, part of the group I was at that time supported it. At the same time now, I'm having some folks reach out to me and saying, we want to use telechaplaincy, not telechaplaincy, but online chaplaincy with our folks that are in nursing homes, or I think they're in living facilities, because they said it's more disruptive to them, for the chaplain to make arrangements to go see them. I don't know how it's going to work out, but again, I think that innovation, finding ways to respond to people's needs and not being limited. If I had listened to all the critics when I started doing online, I don't know where it would be, but I think it is an effective way. Is it the only way? No. It's just a different way.
Thank you. Joe?
So I appreciate the question. In my JCFS job, which is not a hospital-based chaplaincy, it's a community chaplaincy, and I'll be talking about it in response to some of the other questions as well, but we're based in a Jewish social service agency. In fact, it's the cutting edge of Jewish chaplaincy, and I wish there was more of it outside the Jewish community. I've been asked to make referrals, and I wish I could make a referral to Catholic Charities or Lutheran Social Services in Chicago, but I don't have a parallel to what I'm doing there. But in the Jewish community, there's a community sense of responsibility, and so most of our programs in other parts of the country are part of Jewish family service agencies. Now, having said that, during the pandemic, we see clients in different places, in their own homes, in nursing facilities, at a Starbucks, or at the library, or in our offices. I have an office, my team, not all of them do, but we work things out. So during the pandemic, we had to do all of our work online. I don't have the metrics to do a scholarly study. That we need COMISS to find funding and do it. But I will tell you anecdotally, and I think the point is that it's not better or worse, it's different. But in terms of outcomes, anecdotally, I don't sense that the outcomes are dramatically different if it's addressing what we have defined already many times as spiritual needs, if it's helping clients with mental health issues or other types of issues. Those outcomes are certainly there. So we meet people online or in person, depending how things work. One of the advantages of it, you lose something in the process by not being in the same room. You can't read the body language the same way, granted. On the other hand, as Tevye and Fiddler on the Roof used to say, and there always is another hand, right? There always is another hand. You extend the reach of the chaplaincy. So in our community group, we can see clients who live, not outside the Chicago area, but an hour and a half away, which would make it really hard if we were having to schlep down to the southern suburbs of Chicago when we're up north and things like that. Also, in terms of training, our programs, we do a pretty robust training for Chicago area Jewish chaplains. We have a number of different programs several times a year. And doing it in a hybrid fashion, it's kind of clunky, and the tech doesn't always work, but it extends our reach a lot. So people come in person, and those who come in person, we serve food. It works. But some can't or don't or won't, but they come also, and they're able to benefit from what we offer as well.
Yes.
I think, Rabbi, for this last concept, extending the reach of chaplaincy, my question is in the same vein, but not so much in providing the service. It is in training chaplaincy. What I'm hearing here, we're talking about, I like to write my questions so I don't lose. The conversation leave a couple of things unresolved for me in terms of inequality of resources, in terms of training outside of North America. Chaplaincy is so valuable. The very building that we are gathered in is a global church. I do training in Cameroon, I do training in the West Indies and so forth. We talk about a common standard, and so here's my question. What standard is going to be common globally when there's inequality in how clergy are trained? There's no imam here today. There's no Buddhist here today. They're not trained like we train having an M.Div. Talking to my ACPE friend who love to have M.Div as, the gold standard of admission. So what is that standard going to look like? Because I am taking chaplaincy across the globe, and I need help.
That is more than a mouthful. that is one of those unknowable, unknowable unknowns right now. And so I think we're going to have to germinate on that because, again, I'm thinking a lot of these larger questions, and I'm not even a part of the board or task force conversations. Doug?
I'm going to say you raise an important question. Even talking to folks from seminaries, we're seeing a shift from M.Div to other degrees. So they have masters in chaplaincy now. That's like 36 or 48 hours. There's a lot of questions that are right now kind of new in the space that when I started, everybody had an M.Div. And that's basically the only degree you could get was an M.Div. And chaplaincy was second ministry career for most people coming into chaplaincy. They did a church because you couldn't get ordained if you didn't do a church. So they did that second career. Even the military, I think it's 2-3 years they still require of parish service. That's changing now. And that landscape is, you raised a really tough question that you're right. We're kind of in that not knowing and kind of knowing it's unknowable at the moment, but it's a place we're going to have to work.
So let me ask this question closer to home. And I see your hand, Ivan, but let me ask this question closer to home. Or as Joe Madison would say, put it where the goats can get it. Goats eat right down to the root. So with this idea of essential workers, 15, 20 years ago, case management and social work moved away from bedside care. It left a gap. Could it be possibly true that we as professional spiritual care providers can step into that gap that remains because that is essential work? Thoughts? Just curious. And if so, how? Maybe we're already doing it. Anybody? Go ahead.
I'm talking too much. But, looking at it, and I'm going to take advanced directives for a second. Advanced directives either is the domain of a chaplain or a social worker in most facilities. When I started at the current hospital, they said, why don't we give that to the social workers? And my response to my own team was, why would we do that? One, very practically, how many, if we're spending one FTE's worth of people just doing advanced directive and helping with goals of care, that means I don't have to have that FTE. Just being very practical. But really, we work with people and are helping them take their values and translate them into paper so that their values can be carried out, and the people who are going to do that are going to help them. So when we're doing those agents, who's going to be the agent? What's important to them? That fits right into that, Rachel's definition of that spiritual, informed, culturally competent. I can't remember the definition, but it was good. And I said, no, we're the people who need to be doing this because this really is in our wheelhouse of what spirituality is about. And for those who have faith, this is about where their faith meets the reality of their situation. This is our neighborhood. We need to be in this neighborhood. So yes, I think we can step in. I think a lot of the places I've talked to, they have naturally stepped into some of those gaps to take care of people.
I want to pivot here. Gentleman next to Ivan, I don't know your name, so would you, you're unmuted, so Ivan, but I want to go to the gentleman first.
I'm going to introduce him.
Oh, please, there you go.
This is Brigadier General, retired, Andrew Harewood, who is someone who works very closely with me here in this building. And helped me a lot. A good friend. Before I pass over to him, I want to say something about what Asnel was saying. Because being someone who looks at chaplaincy from the worldwide perspective, that's my day-to-day, that's my bread. I have a responsibility to my denomination. When they appointed me director of chaplaincy ministries, I decided that I was going to provide this church with chaplains who have three qualities. And that's, if you walk over to my office, you will see it right there in the wall. We provide the church with chaplains who are competent. We provide the church with chaplains who are committed. And we provide the church with chaplains who are compassionate. The 3 C's of chaplaincy, I call. And I'm looking at the world, and I'm looking at everyone that calls themselves a chaplain in the Seventh-day Adventist Church. In order for them to be called chaplains, in order for them to be endorsed as chaplains, in order for them to carry the responsibilities of chaplains, they have to demonstrate that. So that's the way I'm standardizing worldwide. So if you find a Seventh-day Adventist chaplain in Africa, you can expect them to deliver the 31 competencies of APC. And you can expect them to be trained. That's why I use people like Asnel and others to train them to that level. We cannot. Let me take back that. I cannot afford to lower standards for anybody. Therefore, what I'm doing is anyone who wants to be an Adventist chaplain in the world has to have those 3 C's. And now I'll hand it over to my friend.
You're very gracious. Thank you so much. I want to start by simply saying I so appreciate what all of you are doing. And I know very often we don't take time to pat each other on the back. But the fact of the matter is that, as I was sharing with, I can't remember your name, sir, that we talked earlier, Doug. The fact of the matter is, even in hospitals, next to the physicians, the most educated person is, in fact, the professional chaplain. But that's a different conversation. The second thing I want to say, Rachel, I believe that those 4 items that you mentioned should be in a mission statement somewhere. I don't know what type of organization. Certainly we have several here. But I think what caused me to push my button is what the very last item that you raised, sir, I think is really the nexus for me in terms of how we deliver care across the globe. And I think we've got to be careful that we don't allow the necessary to be held hostage by the perfect. Mm-hmm. And so while on the one hand, I concur that there's some germination that needs to take place, mm-hmm. I also think that that's the type of issue that we need to put on warp speed. Because the fact of the matter is, when someone is hurting, mm-hmm. or hungry or hopeless, whether they're Jew, Muslim, no faith, it is a person that we want to give some kind of. So I really appreciate the discourse, the dialogue. I know that the next couple of days, many of you will be in another forum addressing similar issues. But I do think that we're in a place right now globally where we have to refocus on what it means to be a professional chaplain in the context of what is taking place in the globe. Because the fact of the matter is, in my opinion, even the trained minister across their significant faiths still cannot answer the critical question in time of need. So I thank you so much for the discussion.
Thank you all. In the essence of time, there are 3 more questions. I'm going to go to the next question. 10 minutes, 2:45. That's what time we're supposed to.
15 minutes.
15, okay. I saw 2 hands. All right. Thank you. All right, next question. Chaplains use their unique set of skills and training to expand their roles and enter new and emerging areas of spiritual care, including in ethics, end-of-life planning, dedicated staff care, private practice, and workplace chaplaincy. How have these expanded roles for chaplains impacted their work and how they are perceived within their organizations? How are CPE programs integrating these areas into their curriculum? David, Doug, Garrett, and Augustine, in that order. David.
Thank you. So I've worked at 7 different healthcare systems across my career, starting in 1990. And the way that I personally have experienced the way CPE programs in particular have integrated different areas of what chaplains do in the curriculum. Most recent example of this that I can see on the horizon line with the way we've responded post-COVID is that there's been a real deliberate emphasis in chaplaincy on moral distress with staff. So there's been a lot of attention paid to how chaplains have been really helping in the front line with the moral distress of staff. So there are even organizations, I know there's at least a handful, but there's several that are doing really good work that are publishing to the think tanks that are doing research on how chaplains have affected staff support care. So that's one area. The other area that I can think of where we've done a lot of work, but we need to continue to do this work, is when I think about how first-year medical students at large academic centers are brought in and trained. Chaplains and the work we've done with interdisciplinary teams, Garrett mentioned this a few minutes ago, there's always been a struggle around how we train and integrate with interdisciplinary teams. So one program that I was working with, we actually partnered with the academic school and the College of Medicine so that our students would then be embedded in their health science classes with their first year med students, so that on day one, there'd be conversation about what is a chaplain and what is a doctor. And it wasn't 20 years down the road a conversation that happened, but a day one conversation. And then the students that were the CPE students would stay in their track, and those med students would stay in their track, but they would have constant interdisciplinary cross-dialogue classes together. I think that's a move in the future that's continuing to evolve. I think that you mentioned online and expanding the reach. I think that expands the reach, because the one thing that I'm really focusing on is your question about the international scene. I know that I have been for years now a member of the International Council on Pastoral Care and Counseling. They just met this last year. They only meet once every 5 years. This is a huge question they have on their hands. How do we train and do this across the table with each other all over the world? We've not thought globally well enough, and now here we are sitting in a cultural time where we really have to be thinking globally because the world around us is on fire. So I also think that changing in the curriculum is also a connection to things you just mentioned. We're looking at, it used to be the trend that most chaplains in training in CPE, where were they trained? They were trained in mental health. Well, there aren't no mental health hospitals anymore. 1980s, the Reagan administration, we got rid of them. I grew up in a hometown where that was the thing. So, when I was first board certified as a chaplain, it was 2 tracks. Do you go with the College of Chaplains, or do you go with the mental health chaplains, or do you do both? I tried to do both. That world doesn't exist anymore. So when I think about where we're headed, the curriculum is already changing because we're doing more and more online CPE modules with people all across the world, because in a few years when all the baby boomers in the room retire, we know chaplaincy needs are going to go up and we're going to hire some more people. But then after that generation is gone and it's my Gen X people that are next, I have a hunch that the demographic will go down because my group's not as committed to that structure. So I think the curriculum change with paying attention to culture, but it also, a part of that is right now it's M.Div in competencies and in board certifications, but it's also, I think, Masters of Public Health, Masters of Patient Counseling. We have people in this room that are counselors and psychotherapists, and we're not just talking about chaplaincy curriculum, we're talking about ministry curriculum for how we train. So it's, religious studies, interdisciplinary humanities, healthcare, and healthcare administration, and anything else you can think of. But that world's changing, and that's making direct impacts on the curriculum because we're bringing in people with other skill sets beside the 20-year-olds that I was that went straight to div school.
Thank you. Doug, Garrett, and Augustine.
I don't think I like following you.
That means you have less to say, if he covered everything.
Yeah, I mean, you did a fantastic job. I think the expanding role of chaplaincy is looking for those places. And I do ethics. We're doing end-of-life goals of care. We're doing a lot of those things. And getting that down would, to the CPE programs is really important. Because everybody who comes in my building as a chaplain, I am having to train, and do extensive training so that they can manage and do those goals of care conversations in particular. But also the familiarity with ethics, you talked about that. Because I quickly learned chaplains are the go-to people when you start with an ethics question. In fact, what we try to do in my building is go talk to your chaplain before you put a consult in for ethics. And it's amazing because a lot of them are things that we can quickly solve, don't require a consult, that, oh, that chaplain can handle that for us. So having them familiar and then familiar with our policy and how we do those things is vitally important in driving those basic principles down to a CPE program. And then there's whole new worlds. How do you do telechaplaincy, all of those kinds of things. There's a lot of stuff that needs to move from what we're doing and developing in practice down to that next generation. So, because I want my chaplains to really be able to start out and run and then surpass me.
Thank you. Garrett?
Well, following both of you.
What's left, right?
What's left? Two quick things. One, and Doug, I think you probably hit on this in your earlier presentation. I do think that that in the trainees that I've worked with, even in the community-based setting, trying to encourage them to know that as they work as a part of a staff, that they are providing care up and down the hierarchy. Mm-hmm. That CEO is part of their charge to care for as much as the cafeteria worker or the custodian. So trying to carve out time to develop that care relationship in both directions is really important. The second thing I wanted to mention, I don't think I would make this a part of a curriculum, but I did have a student a couple of years ago who, in addition to being a hospital chaplain, was certified in the Reiki energy work. Mm. And she actually used that modality as a way to provide care for the nurses on the various floors that she was assigned to. And it was one of the most successful and meaningful things that she did there at the hospital. So encouraging that creativity is such an important piece.
Thank you. Augustine.
And I'll make this quick. A couple of things I'd like to add. There are chaplains who work in non-traditional roles in healthcare and other settings. In this particular case, I'm thinking about chaplains who serve as mission leaders, especially in Catholic healthcare organizations, where they really are charged with shaping the mission and identity of the entire organization, ensuring that they are true to their mission, their value, their identity. The other thing I also want to highlight in terms of future training needs might be around areas of leadership within organizations. Chaplains are not trained to be spiritual care or pastoral care directors. Most times we see chaplains kind of live into those roles. And I think being intentional about training and formation in that space would be important. A couple of things we see that's emerging too is in the area of especially in the part of the ministries where I serve around folks with housing insecurity, homelessness around the country, as an increasing demand for presence of chaplains in those spaces, as well as areas around human trafficking and migrant issues. These might be opportunities that are emerging. And again, the way we're beginning to think about it is the chaplain is essentially able to be present where the need is the greatest, right? And in all of these areas, we see human need and the need for a chaplain to respond. Thank you.
Thank you. I'm aware we have 5 minutes left, so let me ask the next question, and we will go with the flow. The demographics have changed. While many are still religious, all are spiritual in how we make meaning. So with the rise of the nuns, not N-U-Ns, N-O-N-E-S, the question is, how are chaplains pivoting in our work in care for the nuns? And how can the CPE programs prepare these aspiring chaplains to interact with non-religious care recipients? Joe, Rachel, David, Garrett, Augustine, and I think we'll be out of time when we're done. Start with you.
Probably right.
Joe.
Thank you. There used to be an old commercial that still may be around for a particular Jewish brand of rye bread. You don't need to be Jewish to love Levy's. You may remember it. I'm going to give you a model that comes out of Jewish tradition. You don't have to be Jewish. It has nothing to do with Judaism in and of itself, but it's a model that comes out of both my tradition, but also the practice that I am currently practicing. I'll start with a one line from the Talmud. I'm a rabbi. I can't resist quoting Jewish tradition. In the Talmud, it says that someone who visits the sick takes away 1/60th of the illness. Now, the exact amount of fraction is not important. I could spend an hour giving you a scholarly study of that. I'm not going to do that right now. But we have evidence. It's evidence-based to know that the things that are involved in a visit, connection, presence, relationship, all things we've spoken about all day today, make a difference. And we have evidence to show that it makes a difference. Now, what we've learned in the last few years is that the Hebrew term for visiting the sick is bikur cholim, visiting the sick. We've had to change the definition of a visit, and we just did it. We spent quite a bit of time in this session talking about, is it online, is it this, is it that? And what is sick? Is it someone who's in a hospital? Well, I don't do hospital work so much anymore. We're talking about people who are lonely, who are frail, who may be elderly, or maybe with special needs, or people dealing with behavioral health issues. So visiting and sick have different definitions here. Now let's talk about the religious piece here, or the spiritual piece. How do you deal with a secular perspective? And again, here's where the Jewish community, our model might be helpful. It's not a model that we created or one that I even like because of the reality that we're facing. The Pew studies have shown that among the various religious groups in this country, my people, my community, the Jewish community, has the lowest rate of what the classical terms of religious engagement would be. We're talking about prayer and synagogue attendance and belief in God and heaven and all this other religious stuff. This is pretty funny. We're the people who brought the rest of you God, and we have the lowest level of engagement. Think about this for a minute. But it's the way it is. So as far as secularity, we've become really good at this. The level of engagement is, maybe in Chicago, maybe half of the Jewish population is involved with the synagogue. And it's more the further west you get. The percentages are higher. So what do you do in a case like that? Well, actually, it involves re-examining the definitions. So from a Jewish perspective, Judaism is not only a faith in the Western sense, or a religion in the Western sense. It's a culture, it's a people, it's a nationality, it's an ethnicity, it's a lot of different things. And those are all valid access points to the tradition and to the community. I would argue that in Judaism, community is a source of spirituality. I don't have the time to give you the whole, it would be an interesting presentation. I'm not going to do it now. But the point is I practice it. So part of our job as chaplains in the Jewish community is tell people access any one of those points. So it may be a matter of culture rather than religion. I'll give you an example.
One last word. Rachel, you have the final word. I'm going to honor our time. Take us home.
Got it.
I'm sorry, Joe. I didn't tell him to do that. I like a lot. I like everything you said, Joe. I really do. I think this is something that CPSP does really well in our training programs. We're focusing on what gives you meaning. Where do you find your hope? What is your existential pain right now? And those things are universal, regardless of what your faith background is. It might influence how you cope with it, but if we're focusing on that, then the patient is going to tell us what it is that they are looking for and how we can best help them.
And with that, let us put our hands together and appreciate our panel. Pat Applehands, you can turn to the mic and let us know what's next.